1, 2,
And maybe 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
So picture this. A 24-year-old woman walks into your emergency department triage. She looks a little pale. She's holding her right shoulder, wincing, and tells you she's been having these dizzy spells since she woke up.
Okay, yeah.
Her blood pressure is 110/70, but her heart rate is sitting at a 115. So as the triage nurse, I mean, your first instinct might be to ask, like, did she lift something heavy?
Sure.
Or maybe she just slept on her arm wrong.
Right, the orthopedic row.
Exactly. You might think about sending her back to the waiting room with an ice pack and some ibuprofen. But if you do that, she might literally be dead in an hour.
Yeah, she absolutely could be.
Because that shoulder pain isn't an orthopedic issue at all. It's actually a massive, catastrophic obstetric hemorrhage, and she's actively bleeding out into her own abdomen.
And see, that is the exact scenario that separates, a task-oriented nurse from a real clinical thinker. Because what the patient is experiencing there is a ruptured ectopic pregnancy. And unless you have the clinical foresight to, ask about her last menstrual period and recognize that physiological connection, the pooling of free blood in the peritoneal cavity causing referred shoulder pain, you miss the window to save her life.
It's terrifying how fast it happens. And that's exactly the landscape we are navigating today. Welcome to the deep dive, everybody. We are stepping straight into the clinical simulation lab for a really specialized mission today.
We are indeed.
We're acting as your elite OB nursing educators, your clinical mentors, and honestly, your exam coaches. Our focus today is obstetric emergencies, specifically complications of pregnancy and hemorrhagic disorders.
And just to set the ground rules here, we aren't going to just sit here and read a textbook at you.
No, please no.
Right. We are aggressively applying the Pareto principle. We are sifting through hundreds of pages of, pathology, pharmacology, and nursing interventions to extract that critical 20% of knowledge.
20% that yields 80% of your exam value.
Exactly. We're isolating the high-yield facts, the mechanisms, and the safety concepts that will make you a safe, prioritized, formidable clinician.
Because to thrive on a real labor and delivery floor or, in a high-stakes testing environment like the NCLEX, you have to establish a baseline of prioritization. You are just perpetually scanning for airway, breathing, circulation, fetal distress, and hemorrhage.
Right. And if you understand the underlying mechanism of why a disease process threatens one of those core priorities, the nursing actions just become intuitive. You won't have to memorize some long list of interventions. You'll just know what the body needs to survive.
I love that. Okay, so let's start at the very beginning of the timeline, right back with that scenario we just mentioned, the ectopic pregnancy.
Let's do it.
Because the cellular mechanics of early implantation are just wild. Trophoblastic tissue, which is the outer layer of the blastocyst, is essentially programmed to behave like, an invasive tumor.
It really is. Its singular biological directive is to dig into tissue and establish a robust maternal blood supply.
Right. And when it does that in the thick, nutrient-dense decidua of the uterus, we get a healthy placenta.
But when that blastocyst gets delayed, which is, often due to scar tissue or maybe inflammation from pelvic inflammatory disease or altered tubal motility, it implants outside the uterine cavity.
And usually that's in the fallopian tube, right?
95% of the time, it nests in the ampulla, which is the widest section of the fallopian tube. And the problem there is purely structural.
Because the tube is tiny.
Exactly. The fallopian tube has this very thin muscularis layer, and it completely lacks the protective, adaptable lining of the uterus. It just cannot accommodate a growing embryo.
But the invasion just continues anyway. The trophoblasts dig right into the tubal wall, eroding the blood vessels. And because the hormonal signals of pregnancy, specifically human chorionic gonadotropin, or hCG, are still firing, the maternal body doesn't even realize anything is structurally wrong.
It's completely tricked. It continues to pump blood to that area. The tube stretches until it physically cannot take the tension anymore, and then it ruptures.
Which brings us back to our 24-year-old in triage. Ectopic pregnancy is literally the leading cause of first trimester maternal mortality, and it is entirely due to hypovolemic shock.
Right. You have to suspect this in any patient of childbearing age presenting with abdominal pain and a positive pregnancy test. You do not, I repeat, do not wait for an ultrasound confirmation to start thinking about hemorrhage.
Yeah, that's a massive priority right there.
Yeah.
So what's the expected versus the concerning here? Because a normal early pregnancy has some weird symptoms too.
Sure. In a typical early pregnancy, you expect a missed period, some breast tenderness, maybe some mild nausea. That's all normal.
Right.
But the red flags for an ectopic, even before it ruptures, are unilateral abdominal pain, so pain isolated to one side of the pelvis, and dark vaginal spotting. This usually manifests around, I'd say, 6 to 8 weeks after their last menstrual period.
Okay, wait, let's unpack that dark spotting. Why is it dark? Is it active bleeding from the tube making its way out?
Actually, no, not necessarily. Often, the altered hormonal state causes the uterine lining to kind of slough off, resulting in that dark old blood.
Ah, okay.
But the real crisis, the urgent priority, is the abrupt onset of severe, stabbing, lower abdominal pain. We are talking about pain that literally doubles the patient over. That means the tube has burst.
And this is where the anatomy of the nervous system gives us that brilliant, though, terrifying diagnostic clue, the referred shoulder pain.
Carrier sign.
Yes. When that tube bursts, arterial blood pours into the peritoneal cavity. As the patient lies flat or even just shifts around, that highly irritating free blood pools upward under the diaphragm.
And the diaphragm, as we know, is innervated by the phrenic nerve.
Right.
If we recall our neuroanatomy, the phrenic nerve arises from the cervical spinal roots C3, C4, and C5. And those exact same nerve roots also provide sensory innervation to the shoulder.
So the brain gets confused.
Completely. The brain struggles to isolate the origin of the visceral irritation, so it misinterprets the massive intra-abdominal bleeding as acute shoulder pain.
That is wild. So on an exam or in the clinic, if an early pregnancy patient complains of shoulder pain, you translate that instantly. Shoulder pain equals internal hemorrhage. They aren't sleeping wrong. They are bleeding internally.
Exactly. You assess those vital signs immediately. And, hey, the classic trap here for students is waiting for the blood pressure to drop to confirm shock.
Oh yeah, don't do that.
Never do that. Hemodynamically, the body compensates first by increasing the heart rate to maintain cardiac output. Tachycardia is your early warning system. Hypotension is a late decompensated sign. By the time the BP drops, you are way behind.
Right. So once you suspect the rupture, your priority nursing actions have to be rapid. You are securing large bore IV access, at least an 18 gauge, because you need the capability to push fluids and potentially blood products.
Yep. And you anticipate orders for a transvaginal ultrasound to locate the mass and serial quantitative beta-hCG blood tests.
And in an ectopic, those hCG levels are going to look weird, right?
Yeah. Right. They will be lower than expected, and they won't double every 48 hours like they do in a normal viable pregnancy.
Okay, and there is a massive contraindication here that examiners absolutely love to test.
Oh, the digital exam.
Yes. You absolutely never, under any circumstances, perform a digital vaginal exam on a patient with a suspected unruptured ectopic pregnancy.
Because if you palpate that adnexal mass, you can physically rupture the tube yourself.
Right. You precipitate the exact hemorrhage you're trying to prevent. Just don't do it.
You also have to think about the immunology of this patient. If the mother's blood type is Rh negative, the exposure to fetal blood during the rupture or the surgery requires the administration of Rh immune globulin, or RhoGAM.
And that has to be within 72 hours.
Exactly. Right? This prevents the mother's immune system from forming antibodies against the Rh factor, which would cause hemolytic disease of the newborn in her future pregnancies.
Perfect.
Yeah.
Now, what if we catch the ectopic before it ruptures? Because the pharmacological intersection here is kind of fascinating. We use methotrexate.
Which always surprises students.
Yeah, because it's a known chemotherapeutic agent. It's a highly toxic drug, and we are giving it to a pregnant patient.
But the mechanism of action is precisely why it works. Methotrexate is a folic acid antagonist. It binds to the enzyme dihydrofolate reductase, which completely halts the synthesis of DNA and RNA.
And because the trophoblastic cells of the ectopic pregnancy are dividing at this incredibly rapid exponential rate, they're uniquely susceptible to this targeted disruption.
Exactly. By administering methotrexate, we can dissolve the pregnancy tissue medically, completely bypassing the need for surgery.
Which is a huge clinical win because it preserves the integrity of the fallopian tube and safeguards the patient's future fertility.
But the criteria for who gets methotrexate is a prime testing target because it requires really strict patient safety parameters.
Right, you can't just give it to everyone.
No. The mass must be unruptured and relatively small, typically less than 4 centimeters. The beta-hCG must be under 5,000. But most critically, the patient must be hemodynamically stable.
So if their heart rate is 120 and they are dizzy,
then the tube has likely already compromised, and a slow-acting drug like methotrexate is totally useless. They need a stat surgery.
makes sense. What about the nursing implications for methotrexate? There's a lot of patient teaching there.
A ton. As a folic acid antagonist, its efficacy can be completely neutralized if the patient consumes folic acid. You must explicitly teach them to stop taking their prenatal vitamins because those are loaded with folic acid.
Oh, that's a huge exam point. Stop the prenatals.
Yes. They also need to avoid alcohol, as methotrexate is hepatotoxic, and the liver is already working overtime to process the drug.
And the follow-up for this is non-negotiable.
Absolute. They must return to the clinic on day 4 and day 7 post-injection for follow-up quantitative hCG titers. We have to prove the drug actually arrested the cellular division.
We are looking for a specific percentage drop. Right.
Exactly. Furthermore, they need to use highly reliable contraception for at least 3 menstrual cycles afterward. The drug remains in the system and could cause severe teratogenic effects to a new embryo. Plus, the reproductive tract simply needs time to heal.
Okay, so if we're coaching them for the exam, if you only remember 5 things about ectopic pregnancy, what are they?
Okay, top 5. 1. Unilateral abdominal pain with a missed period mandates high suspicion. 2. Referred shoulder pain is the somatic alarm bell for intraperitoneal hemorrhage. 3. Methotrexate is reserved strictly for the stable, unruptured patient. 4. Follow-up hCG titers are mandatory. And 5. Always give RhoGAM to Rh-negative mothers.
Love it. Clear and prioritized. Okay, moving forward on our timeline, let's look at what happens when the embryo actually navigates the fallopian tube successfully and implants in the correct location, the uterus, but the pregnancy itself is biologically unviable.
Right, transitioning to the spectrum of spontaneous abortion, which clinically we refer to as miscarriage.
This is an area that demands a really seamless blend of sharp physiological understanding and just profound psychological tact. Because from a purely clinical standpoint, the terminology can be really overwhelming.
It's a lot of words. Imminent, incipient, incomplete, complete, missed, septic.
Right. So how is a nursing student supposed to keep these straight on a fast-paced exam?
Okay, so the physiological anchor here, the definitive diagnostic key, is the cervix.
The state of the cervix.
Yes. The cervix is a dense, fibrous ring of connective tissue that acts as the mechanical gatekeeper of the uterus. When we evaluate a patient experiencing early pregnancy bleeding, we are looking directly at that gate to determine what happens next.
Okay, so let's break down the hemodynamics using that door analogy. What about an inevitable or incipient miscarriage?
So the patient presents with moderate to heavy bleeding and cramping. When the provider visualizes the cervix with the speculum, the internal os is open. The structural integrity of the pregnancy has failed, and the process cannot be reversed. The door is open.
Got it. And when that progresses to an incomplete miscarriage, it becomes a severe hemorrhagic risk, right? Heavy bleeding, intense cramping, and partial passage of tissue.
Yes, the cervix is open, but some of the products of conception, often fragments of the developing placenta, remain attached to the uterine wall.
And the physiology of why retained tissue causes such massive bleeding is critical to understand, because the uterus normally controls bleeding by contracting its interlacing muscle fibers, the myometrium, around the spiral arteries that feed the placental site. It acts like a biological tourniquet.
Right, but if a piece of tissue is retained, it acts like a wedge holding the door open.
Exactly. The uterus cannot clamp down effectively. The spiral arteries remain open, and the patient just bleeds and bleeds.
Which is exactly why an incomplete miscarriage requires immediate intervention, either medically or via a surgical dilation and curettage DNC, to empty the cavity so the myometrium can finally contract.
Now, if the process finishes naturally, we have a complete miscarriage. All tissue is expelled, the uterus is finally empty, the biological tourniquet works, the bleeding subsides, the cramping stops, and crucially, the cervix closes back up. The door is shut.
Right. But the physiological outlier here, the one that is so devastating for patients, is the missed abortion.
Because there are no outward alarm bells.
None. The fetus loses viability in utero, but the maternal body fails to recognize the loss. The cervix remains tightly closed. There is no bleeding, no cramping.
So how do they even know?
The only clinical clue is that the patient might notice their early pregnancy symptoms, the nausea, the breast tenderness, just kind of slowly fading away as the hCG levels drop. And it's usually caught on a routine ultrasound when there's no fetal heart tone.
Heartbreaking. And if a missed or incomplete abortion goes untreated, we face the risk of a septic miscarriage, which is incredibly dangerous.
Extremely. The retained necrotic tissue becomes a highly vascularized petri dish for pathogens, often ascending from the vaginal flora. We start looking for systemic signs of infection. A fetid, foul-smelling vaginal discharge, severe pelvic tenderness, and an escalating fever.
And the microbiology here is scary. Often, these are gram-negative bacteria that release endotoxins into the maternal bloodstream. This triggers a massive systemic inflammatory response. The capillaries become super permeable, fluid leaks out of the vascular space, and the patient goes into endotoxic shock.
Their blood pressure plummets while their heart rate skyrockets, trying to perfuse vital organs with a depleted intravascular volume.
So your priority nursing actions have to be focused on perfusion and quantitative assessment. You do not just ask the patient if the bleeding is heavy. That's subjective.
Right. You count the pads, you weigh the Chuck's pads. 1 gram of weight equals 1 milliliter of blood loss. You monitor the vital signs for that narrowing pulse pressure and rising heart rate that indicate compensatory shock.
Now, regarding the pharmacology for a miscarriage, we frequently see a combination of mifepristone and misoprostol. The mechanism of these drugs is highly testable because the intended effects actually mimic an emergency.
They really do. So mifepristone is an antiprogestin. It blocks the progesterone receptors, essentially starving the pregnancy of the hormone it needs to stay attached.
And then, 24 to 48 hours later, they take misoprostol.
Right, which is a synthetic prostaglandin E1 analog. Prostaglandins cause powerful rhythmic contractions of the myometrium and soften the cervix.
And here's a classic NCLEX trap for students. A patient will call the clinic reporting intense, painful uterine cramping and heavy bleeding with clots after taking misoprostol. A novice might interpret this as an adverse reaction or a hemorrhage requiring the ER.
But physiologically, this is the exact intended mechanism of the drug. It is artificially inducing the expulsion of the uterine contents.
Right. You anticipate this, you prepare the patient for it with appropriate analgesics, and you educate them on the specific threshold of bleeding that actually warrants an ER visit, like soaking more than 2 maxi pads an hour for 2 consecutive hours.
Exactly. And alongside the pharmacology, the psychosocial nursing interventions are paramount here. You must validate the profound emotional trauma of the loss.
Avoid the platitudes.
Please, do not tell them they are young and can try again. You meet them in the reality of their current grief. The physiological stabilization and the psychological support carry equal weight.
Absolutely. Okay, let's bring it back to the exam coach mode. If you only remember 5 things about the spectrum of miscarriage.
Okay, 5 things. 1, open cervix means inevitable or incomplete loss. 2, closed cervix with a dead fetus is a missed abortion. 3, retained products mean high risk for hemorrhage and sepsis. 4, misoprostol expels tissue, expect heavy bleeding and cramping, it's not an adverse effect. And 5, emotional support is a critical clinical intervention.
Nailed it. Okay, moving on. We've covered the embryo implanting in the wrong place and the embryo failing to survive in the right place. But there is a third, really bizarre physiological fake-out that occurs in early pregnancy.
Oh, yes.
The pregnancy test is positive, the uterus is expanding rapidly, the patient is experiencing severe, debilitating nausea. But there is no viable embryo at all.
It's Gestational Trophoblastic Disease, or GTD, which everyone calls a molar pregnancy.
It's like planting a seed, but instead of a flower, you get a rapidly expanding, aggressive weed that just takes over the entire garden.
That's a great analogy. The cellular genesis of this condition is incredible. It is an abnormal, aggressive proliferation of that trophoblastic tissue we discussed earlier, but the genetic sequencing is entirely chaotic.
Let's break down the complete mole, which is about 80% of these cases. It starts with an enuclear ovum, an egg, that, for whatever reason, has lost its maternal nucleus and contains no maternal DNA. It's an empty shell.
And this empty egg is fertilized by a normal sperm. Because the egg is empty, the sperm's genetic material simply duplicates itself to achieve the necessary 46 chromosomes.
Resulting in a karyotype that is entirely 100% of paternal origin.
Right. And in human embryology, the paternal genes primarily drive the development of the placenta and the trophoblasts, while the maternal genes drive the development of the fetus.
So in a complete mole, Because there is no maternal DNA to act as a biological counterweight, no fetus develops whatsoever.
Exactly. Instead, the paternal genes go into absolute overdrive, creating a massive, rapidly proliferating tumor of chorionic villi that swell into transparent, fluid-filled, grape-like vesicles.
Now, the partial mole, the other 20%, is slightly different. A normal egg with maternal DNA is fertilized simultaneously by 2 different sperm. So you get a triploid karyotype, 69 chromosomes.
Because maternal DNA is present, there may be some disorganized fetal tissue, but the massive chromosomal anomaly makes it completely incompatible with life. The tissue still proliferates abnormally, just slightly less aggressively.
The clinical presentation here is driven entirely by the endocrinology of that massive, overgrown trophoblastic tissue. Trophoblasts secrete hCG.
And because there are millions of these abnormal vesicles, the beta-hCG levels skyrocket to astronomical heights, way beyond a normal pregnancy or even twins.
And that astronomical hCG level is the domino that knocks over all the other clinical symptoms. First, it causes the uterus to expand much faster than normal. A patient who is 10 weeks pregnant might look like they are 20 weeks pregnant.
Second, it causes severe, intractable nausea and vomiting hyperemesis.
The bleeding associated with GTD is also really unique. It's frequently described as dark brown, resembling prune juice.
Yeah, that happens because the rapidly expanding vesicles rupture inside the uterus and the old blood eventually makes its way out.
But the most critical, heavily tested red flag regarding molar pregnancy involves the cardiovascular system, specifically early onset preeclampsia.
This is a vital connection to make for exams. Preeclampsia is classically a disease of the 3rd trimester. It almost never occurs before 20 weeks of gestation. However, the massive abnormal trophoblastic tissue of a molar pregnancy releases massive amounts of anti-angiogenic factors into the maternal bloodstream, severely damaging the maternal endothelium much earlier than a normal placenta ever could.
So the absolute rule is, if you have a pregnant patient presenting with hypertension and proteinuria at 14 or 16 weeks, it is a molar pregnancy until an ultrasound proves otherwise.
Exactly. And when you perform that transvaginal ultrasound, the classic diagnostic finding isn't a gestational sac, it's a snowstorm pattern.
The ultrasound waves hit the hundreds of tiny vesicles and bounce back, creating this dense, granular, static-like image on the screen.
Right. Once that is identified, the priority nursing action is to prepare the patient for an immediate surgical evacuation of the uterus via suction curettage. But the most critical phase of care actually happens after the surgery.
The postoperative teaching is literally a matter of life and death because GTD is a premalignant condition.
Up to 20% of complete molar pregnancies will undergo a malignant transformation into choriocarcinoma, which is a highly virulent, aggressive cancer of the trophoblastic cells that readily invades the myometrium and rapidly metastasizes, most commonly straight to the lungs.
And the only way we can track if this cancer is developing is by using beta-hCG as a tumor marker.
Right. If the tissue is completely removed and no cancer is developing, the hCG levels will steadily drop to 0. But if a few microscopic cells mutated into choriocarcinoma, they will continue to secrete hCG, and the blood levels will plateau or rise.
Therefore, the patient must commit to a rigorous schedule of blood draws. Weekly beta-hCG monitoring until the levels are completely undetectable for 3 consecutive weeks, followed by monthly draws for 6 to 12 full months.
And the absolute non-negotiable rule during this entire monitoring period is strict, highly reliable contraception. They cannot get pregnant for 1 full year.
Because if they do, a developing normal placenta will start secreting hCG. And if we see a rising hCG level on their lab report, we will have a terrifying diagnostic dilemma. We won't know if we are looking at a healthy new pregnancy or a massive resurgence of metastatic cancer.
We lose our only reliable tumor marker.
This is why examiners love to test therapeutic communication here. You might see a multiple choice option where the nurse says, you can try for another baby in a few months when you feel emotionally ready. It sounds empathetic, but clinically, it is a lethal error.
You must firmly educate them on the physiological necessity of a 1-year delay.
Okay, hit me with the 5 things for molar pregnancy.
Number 1, complete mole equals no baby, only grape-like cysts, 100% paternal DNA. 2, hallmark signs are prune juice bleeding, hyperemesis, and a huge uterus. 3, preeclampsia before 20 weeks is molar pregnancy until proven otherwise. 4, treatment is an immediate D&C. And 5, 1 year of strict birth control and hCG tracking to watch for choriocarcinoma.
Brilliant. Now, we noted earlier that the massive hCG levels in a molar pregnancy cause extreme nausea. Let's actually isolate that symptom and look at it as a primary pathology, hyperemesis gravidarum, or HG.
Yes, let's unpack that.
Because this is a diagnosis that suffers from a lot of societal misunderstanding. People equate it with standard morning sickness, and they suggest, like, eating some saltines or drinking ginger ale.
Which is incredibly frustrating for patients.
Totally. As a clinician, you must understand that HG is not just nausea. It is a profound state of systemic depletion and starvation metabolism. So how do we definitively prove to an examiner or a skeptical relative that HG is entirely different?
The physiological boundary is marked by objective, measurable deficits. Normal nausea usually revolves by the end of the first trimester, and the patient maintains their weight and hydration. HG is intractable. It is vomiting so severe that it leads to a fluid volume deficit, electrolyte imbalances, and clinical starvation.
And the definitive testable metric is what?
Weight loss usually exceeding 5% of their pre-pregnancy body weight.
That's a massive number. Let's break down the exact metabolic cascade that makes HG so dangerous. First, the continuous vomiting violently expels hydrochloric acid from the stomach. You are actively losing hydrogen and chloride ions. This massive loss of acid forces the blood into a state of metabolic alkalosis.
Right. And in response to this alkalosis, the kidneys attempt to compensate by holding on to hydrogen ions in the renal tubules. But to do that, they have to excrete potassium in exchange.
Plus, the patient isn't taking in any dietary potassium because they can't keep food down.
Exactly. This leads to severe hypokalemia.
And hypokalemia is terrifying. Potassium is the primary intracellular ion responsible for the repolarization of the cardiac muscle. When potassium drops, the resting membrane potential of the heart becomes unstable. You start seeing prominent U waves on an ECG, and the patient is at immense risk for lethal ventricular arrhythmias.
And on top of the electrolyte crisis, the patient is starving. Because they have no glucose intake, their hepatic glycogen stores are rapidly depleted. To keep the brain and vital organs functioning, the body shifts into lipolysis. It starts breaking down its own fat stores for energy.
And the byproduct of this rapid fat metabolism is the production of ketone bodies.
Right. Acetoacetate and beta-hydroxybutyrate. So when a patient presents to triage with suspected HG, a simple urinalysis provides a wealth of data. You are looking specifically for ketonuria.
High ketones in the urine confirm that the patient has exhausted their glucose and is actively consuming their own fat. You also look at the urine-specific gravity. A high reading indicates the kidneys are desperately conserving water because the intravascular volume is critically low.
The clinical presentation will reflect this profound dehydration. Poor skin turgor, dry mucous membranes, and a compensatory tachycardia as the heart tries to circulate a reduced blood volume.
So priority nursing actions. This is a common trap for novice nurses. You see a dehydrated patient and think, I need to get her to drink some water.
Oh yeah, choosing encourage oral fluids as the first action. Trap.
Huge trap. Introducing anything into a highly sensitized spastic gastrointestinal tract will only trigger more vomiting, worsening the alkalosis and potassium loss.
The immediate priority is NPO status initially to completely rest the GI tract. Simultaneously, you start IV fluids, usually lactated ringers or normal saline, and administer 5E antiemetics.
And you never start with a dextrose solution like D5W.
Right, because administering glucose to a severely malnourished patient without concomitant thiamine can trigger Wernicke's encephalopathy, a severe neurological complication.
Wow. Okay, so once the vomiting is controlled, then what?
Only then do you slowly introduce clear liquids, then small, frequent, bland meals. Check urine for ketones, monitor electrolytes, and again, provide intense emotional support. It severely impacts mental health.
Okay, 5 things for HG.
1. Defined by greater than 5% weight loss and dehydration. 2. Look for ketonuria as a sign of starvation. 3. Priority intervention is IV fluid replacement, not oral feeding. 4. Keep patient NPO until vomiting is controlled. And 5. Emotional support is critical.
Excellent. Okay, moving along the timeline. Nausea is fading, first trimester is over. But a new structural problem can emerge in the second trimester. Cervical insufficiency.
Historically called an incompetent cervix.
Right. And this is terrifying because it lacks the dramatic alarm bells. Labor is supposed to be painful, right? So how can someone dilate and lose a pregnancy without even realizing they are in labor?
Well, the physiology comes down to the microscopic composition of the cervical tissue. The cervix is not primarily muscle. It is a dense matrix of connective tissue, mainly collagen and elastin. It acts as a biological drawstring.
Holding the heavy uterus closed.
Exactly. In a patient with cervical insufficiency, there is a structural defect in that collagen matrix. The tissue simply lacks the tensile strength to withstand the increasing hydrostatic pressure of the amniotic sac and the gravitational weight of the developing fetus.
The tissue just mechanically yields. The cervix silently effaces and dilates right in the middle of the second trimester, typically 14 to 20 weeks.
And the patient might present with incredibly vague symptoms: pelvic pressure, pink-tinged discharge, or feeling like something is in the vagina, which is actually the amniotic sac bulging out.
The diagnostic distinction here is crucial, and it relies on the TOCO dynamometer.
Yes. The TOCO measures the tension of the maternal abdominal wall to detect uterine contractions. In true preterm labor, the TOCO shows distinct mountain peaks. But in cervical insufficiency, the TOCO shows a completely flat line.
0 contractions.
Right. The uterus is perfectly relaxed. The dilation is purely mechanical.
And the definitive diagnostic tool is the transvaginal ultrasound, which measures cervical length. Less than 25 millimeters is a huge red flag, and it also detects funneling.
Funneling is fascinating because the pressure is coming from above. The internal os starts to open first, while the external os remains closed. On ultrasound, it looks like a V shape or a funnel.
If we catch it early, the intervention is a cervical cerclage.
Right, a physical fix for a physical problem. The surgeon weaves a heavy suture around the cervix in a purse string fashion, tying it shut.
But the contraindications for placing a cerclage are intensely tested. You cannot place one if the amniotic membranes have already ruptured.
No, if the water is broken, sewing the cervix shut will trap ascending bacteria inside the uterus, guaranteeing a severe chorioamnionitis.
And you absolutely cannot place a cerclage if the patient is having actual uterine contractions.
If the uterus is actively trying to push the baby out, and you sew the only exit shut, the immense force will cause the uterus itself to rupture. Massive internal hemorrhage.
So on an exam, you have to differentiate premature labor, which needs tachylytics to stop contractions, from cervical insufficiency, which needs a cerclage. Okay, 5 things for cervical insufficiency.
1. Painless dilation in the second trimester. 2. TOCO will show NO contractions. 3. Ultrasound shows cervical length under 25 millimeters and funneling. 4. Treatment is a cervical cerclage. 5. Cannot perform cerclage if membranes are ruptured or infection is present.
Okay, we've reached the third trimester. This is the Super Bowl of OB nursing exams. If you don't know the difference between placenta previa and placental abruption, you will fail the exam, and more importantly, you could really harm a patient.
Oh, absolutely. The hemodynamics, the pain pathways, the nursing actions, they are entirely distinct.
I picture previa as a blocked doorway. The placenta is sitting right over the exit. And I picture abruption as wallpaper, violently tearing off a wall before the room is empty.
That's a perfect visual. Let's start with the anatomy. Placenta previa is a positional pathology. The blastocyst implanted abnormally low in the uterine cavity.
Right, so as the lower uterine segment naturally thins and stretches to prepare for labor, the physical shearing forces tear the fragile placental blood vessels away from the uterine wall.
Exactly. Placental abruption, on the other hand, is when the placenta implants in a healthy location, but a sudden, violent physiological event causes it to prematurely tear away from the uterine wall after 20 weeks.
Often linked to profound vasoconstriction or vascular trauma. Severe hypertension, preeclampsia, or cocaine use causes the spiral arteries to spasm violently, rupture, and create a high-pressure hematoma behind the placenta that forcefully rips it off the wall.
Now, the clinical presentation is a study in contrasts. Let's look at the bleeding. In previa, the bleeding is bright red. It's fresh, oxygenated blood flowing directly out of the cervical opening.
But in abruption, it's often dark red, port wine color. It's old blood that has been trapped behind the placenta.
But the most defining diagnostic clue is the pain. Placenta previa is completely 100% painless. A patient might just wake up lying in a pool of bright red blood, feeling perfectly fine.
Conversely, placental abruption is brutally painful. Patients describe it as a tearing, knife-like pain, unrelenting.
And that pain is related to uterine tone. In previa, the uterus is soft and relaxed. But in an abruption, blood is forced into the myometrium, causing it to spasm. The uterus feels as rigid and hard as a wooden board and is highly tender.
The impact on the fetus is immediate. In previa, fetal heart rate is usually normal. But in an abruption, the fetal monitor will almost instantly display signs of profound hypoxia, severe fetal distress.
Because of these differences, your priority nursing interventions are completely different. For placenta previa, the absolute rule: never do a vaginal exam.
If you stick your fingers through the cervix, you will puncture the placenta and cause catastrophic exsanguination, instant failure on an exam. The intervention for previa is bed rest, Monitor bleeding, prep for C-section.
But for an abruption, you are in a crash code level emergency. Your immediate priority is massive volume resuscitation. Start 2DO large bore IVs, left lateral position, high flow oxygen, continuous fetal monitoring. Prep for stat C-section.
And beware the vital signs trap here. Pregnant women have 30 to 40% more blood volume. They can lose massive amounts before BP drops. Tachycardia is your first sign of shock.
Exactly. All right, 5 things. 1, previa equals painless bright red blood, soft uterus. 2, abruption equals painful, dark red blood, rigid, board-like uterus. 3, absolutely no vaginal exams for previa. 4, abruption requires 2 large bore IVs and rapid volume resuscitation. 5, watch the heart rate, not just the blood pressure for early shock.
Now, if a placental abruption is severe enough, it triggers a terrifying systemic cascade called DIC, disseminated intravascular coagulation.
Yes.
And this confuses students. The patient is bleeding to death, but the disease is called intravascular coagulation.
Oh.
How can they be clotting and bleeding at the same time?
Well, massive tissue trauma dumps tissue factor or thromboplastin into the blood. The body panics and creates millions of microclots everywhere.
And because it used up all the clotting factors and platelets to make these useless microclots, the tank is empty. There's nothing left. So the patient then bleeds out from every orifice.
Yeah.
It's a consumption coagulopathy.
Exactly. You'll see bleeding from IV sites, bleeding gums, petechiae. Labs will show decreased fibrinogen and platelets, prolonged PT and 8PT, and a hugely positive D-dimer, which shows massive clot breakdown.
The priority nursing action. You
Yeah.
must treat the underlying cause. DIC is never a primary disease. You have to fix the trigger, deliver the baby and placenta immediately if it's an abruption.
While doing that, administer blood products, FFP, cryoprecipitate, packed RBCs, and platelets, and monitor for renal failure.
5 things for DIC. 1, it's a consumption coagulopathy. 2, first physical signs are bleeding from gums and IV sites. 3, labs show low platelets, fibrinogen, high PT and D-dimer. 4, never a primary disease, fix the trigger. 5, replace what is lost with FFP, cryo, blood, platelets.
Okay, for our final deep dive into the simulation lab, let's look at placental implantation abnormalities, accreta spectrum, and vasa previa.
Previa is about where it attaches. Accreta is about how deeply it attaches. A normal placenta peels off cleanly. But with the previous C-section scar, the placenta invades too deeply.
Right. Accreta is into the myometrium. Increta is deep into the myometrium. Procreta is through the myometrium, sometimes into the bladder.
And the danger is massive postpartum hemorrhage, because it won't detach naturally. A massive NCLEX trap is thinking you can just pull harder on the umbilical cord. If you do that, you cause uterine inversion and catastrophic bleeding.
Exactly. Accreta often requires a planned scheduled C-section with a massive transfusion protocol and a likely immediate hysterectomy.
And vasa previa.
Fetal blood vessels cross the amniotic membranes directly over the internal cervical os. When the water breaks, the fetal vessels tear.
And the bleeding is entirely fetal blood. The baby can exsanguinate in minutes. You'll see painless vaginal bleeding immediately following rupture of membranes, with severe variable decelerations. Stat C-section is required.
Right. So 5 things. 1, prior C-sections massively increase accreta risk. 2, accreta often requires planned C-section hysterectomy. 3, do not manually force an accreta out. 4, vasa previa equals fetal vessels crossing the cervix. 5, rupture of membranes in vasa previa means immediate fetal hemorrhage.
We have covered incredible ground today. From the explosive risk of an ectopic to the mechanical failure of the cervix, the cancer-linked endocrinology of a molar pregnancy, and the violent hemorrhagic battlegrounds of the 3rd trimester.
And mastering this physiological knowledge is what elevates you from a student trying to pass a test to a clinician who commands a room. You become the nurse who catches the subtle drop in fibrinogen, who stops the resident from doing a vaginal exam on a previa. You save lives.
That is exactly why we dive so deep. And before we close, a final thought to ponder. We marvel at the fetus, but the placenta is a temporary organ that acts like a cancer-invading tissue to get blood supply. But in a healthy pregnancy, it knows exactly when to stop invading. If we can fully unlock how trophoblastic cells know when to stop, like they failed to do in accreta or molar pregnancies, could we unlock the cure for cancer metastasis itself? Something to chew on during your next clinical shift. Keep thinking critically, keep prioritizing, and we will catch you on the next deep dive.